Okay, we're going to talk about, we're going to kind of dance around and then go into detail, an article that will haunt you. This is a scientific article that there's only one in the entire medical literature, just appeared about a year ago, on evidence-based indications for cannabis. And the reason it's going to haunt you, I think, will become apparent. So the original idea behind the talk is medical cannabis ready for evidence-based medicine? But actually the real talk is evidence-based medicine ready for medical cannabis? And I suspect you will conclude, I hope, as I did, that the answer is no. And then first, I have no conflicts of interest. Nobody's bribed me yet, but you know, I'm open if there's somebody who want to bribe me out there. And I recognize, like especially yesterday with Dr. Russo, there are lots of people, and lots of people even today who know stuff about cannabis that I don't know. I'm sure you're all convinced at this point that it's an enormous, complex field, and we all have a lot to teach each other. Louder? Hear that? Okay. I think he's got his, if I get too close, it goes like that, so that's why I'm holding back here. Maybe turn it, okay? Is that better? Okay. Just because I'm louder doesn't mean you'll understand me. So. Okay, so what is evidence-based medicine anyway? And this is important because it's not what you think it is. Evidence-based medicine is a way of grading evidence in clinical trials and put into categories. So there's high quality, moderate quality, low quality, very low quality, and then there's stuff that falls off the back of the truck. It's no quality. And it's really about the studies. It's not necessarily about the content. We have to keep that in mind. When politicians and other people who want to tell you what to do are basing it on evidence-based conclusions, what they're talking about is typically the quality of the methodology, not the quality of the information. And this is how you come up with high, moderate, low, very low. You can't even get into moderate or high unless it's a randomized trial. Well, we who are trying to learn about medical cannabis are screwed right from the beginning because there's so few randomized trials, because as we talked about before, you can't blind somebody who's getting a THC preparation. I mean, they know what they're getting because you can feel it. You know the difference between that and placebos. So it means that almost all of the randomized controlled trials just end up with all kinds of methodologic problems. And most of the studies that we deal with are so-called observational studies. So they're going to be low down on the list. And then there's some modifiers, depends on how big the study is and whether it kind of makes sense in the first place, then you can get graded up or graded down. But you can't even get into the top two categories there unless you're an RCT. Now, the problem with evidence-based medicine is how it's used, because it's used to tell us what to do, often by people who don't really know what to do, but they're using the evidence-based medicine as a way of covering their ignorance. And we'll look at a couple examples, good, solid American examples of ignorance. First-line therapy is moderate or strong, level 1 or level 2, based on solid research, and it means if more studies are done, it's probably not going to change the conclusions. Second line is maybe when more studies are done, we'll have a different attitude about it. And third line is we don't really have any good data, but some smart guy, Dr. McCue said to do this. So, why not? I'll do what he says. That's pretty bad. That's third line therapy. So here is one of the problems with evidence-based medicine. This is a direct quote from an article, a nice article, on PTSD. The role of medication in the treatment of chronic PTSD is controversial, especially the question of whether any medication should be considered first-line therapy. SSRIs, particularly sertraline and paroxetine, comprise the only class of medication approved for the treatment of PTSD. However, the 2008 Institute of Medicine report concluded there's no evidence that any class of drugs, including SSRIs, was effective. Similarly, the most recent clinical practice guidelines from the UK, NICE, N-I-C-E, recommended that medications be considered second line and cognitive-based therapies, which are really inferior, as first line. Yet numerous professional societies, including the APA, the World Federation of Societies of Biologic Psychiatry, the US VA, the Department of Defense, suggest that SSRIs and SNRIs are as effective as the evidence-based psychotherapies for PTSD. So here's the punchline. It is notable that all of these reports are essentially reviews of the same research. None of these august, powerful groups had anything different to work with. They all looked at the same stuff and they came up with different conclusions. There's a big problem there with evidence-based medicine if somebody else is going to tell you what to do based on these recommendations. Now remember this from yesterday. Okay, there are nearly 40,000 papers cited in PubMed on cannabis. So here is the JAMA article. Now JAMA, Journal of the American Medical Association, is generally considered the #2 journal in the world. #1, I think generally being accepted, is the New England Journal of Medicine. JAMA has a much larger circulation than New England Journal of Medicine, but it's not nearly as august and scientific. So this is the only meta-analysis, evidence-based medicine analysis of medical uses for cannabinoids. They started with 24,000 articles. Then somehow 15,000 articles got lost in there. And they then excluded 98%. So out of the 23,754, 23,249 got thrown away. Wow. So we're left with 2% of the world literature. They ended up with 504 full reports of randomized clinical trials. So you can't even get into this unless you're a randomized clinical trial. So you've just excluded most of the good cannabis data right there. And then there were some methodologic problems, and they ended up with 79 papers out of 23,754. And they had 10 topics: chronic pain, spasticity, nausea and vomiting, appetite stimulation, sleep, glaucoma, Tourette, depression, anxiety, psychosis. How did they come up with those 10? Well, some people in Switzerland said, here's a list, here's some money. Now, is that a reason for you to adapt your practice to their conclusion because some guys in Switzerland had some money and gave it to the Brits to do the study? It doesn't make a lot of sense. You can't draw conclusions about clinical syndromes that you don't study. So what about other stuff that cannabis works for, like inflammatory bowel disease? We'll talk about it. They didn't look at it. And there are randomized clinical trials of inflammatory bowel disease. So here's their conclusions. Nothing was high quality. 2 indications, pain and spasticity, were moderate quality. Nausea, vomiting, weight gain, sleep disorders, and Tourette syndrome, low quality. Very low quality, depression, psychosis, and anxiety. Now, actually, depression probably is not a good idea. I mean, I would say there is no quality for depression. I think that the people who were doing the analysis here didn't know anything about cannabis. I mean, honestly, these people, these are lab geeks. They probably have never seen a cannabis patient in their entire career. And glaucoma just fell off the back of the truck, and that's probably correct, that you probably shouldn't be using cannabis for glaucoma unless you have absolutely no choice. Now, you can use it in addition, but you got to use your meds. And here are two charts from it that will show you another problem with evidence-based medicine. This is pain, and I don't know if you're used to these, probably not. The column on the far right is a weight. Now, the results of these studies is weighed according to basically the number of patients. So big studies get more weight when they combine. And the line in the middle means no difference. So if you're on the left, placebo is better than cannabinoids. If you're on the right, cannabinoids are better than placebo. And then down at the bottom, those big diamonds, right down there, that's the conclusion. And it has to cross the line, which it barely does, but it just gets across the line. Now, there's something interesting about this. The top study is a study of smoked cannabis, weed. The rest of the studies are all Sativex. So what's going on here? Where is everything else for pain? I mean, pain is hugely documented. Why are they all Sativex studies? Well, there's a reason for that. I mean, it's not that Sativex bought them off. That's not the reason. The reason is that evidence-based medicine analyses are biased towards the kind of study that gets you approval by the US FDA. And the Sativex studies were designed to get approval by the US FDA. So here's another example, spasticity. Same thing, predominantly Sativex studies, and just a few other studies. And this one is even more cryptic, but also barely favors cannabinoids. Yes? Okay. Yes. Yes, it's a generic. All right. In this article, the biximols was a combination of THC and CBD. I didn't look at each one of these studies. It's possible that some are combinations of the two rather than Sativex, and some of them may have been oral. I don't know. Okay. Right next to this article was a case study. Mr. Z is a 60-year-old man who had chronic low back pain and left leg radicular symptoms since he fell at work 19 years ago. Exhausting all medical and surgical options, he began using marijuana. Now remember, marijuana is not a nice word. It's a biased word. For pain relief after receiving a recommendation from a cannabis clinic. He uses marijuana at home in the evening after returning from work. He has found marijuana to have a sedative effect, enabling him to get a good night's sleep and to have less pain the next day. Okay, this is like about maybe 75% of the patients I've seen. This is a very typical case. Older guy, back pain, comes home from work, can't relax, can't sleep because of the pain. and uses cannabis to relieve the pain and to help him sleep. The expert, however, says the course of the treatment may have been altered if Mr. Z had a discussion with his primary care physician prior to obtaining a medical marijuana certification. They may have opted for a treatment of one of the FDA-approved cannabinoids, dronabinol or nabilone, THC or a THC-like synthetic, despite Mr. Z's medical history of anxiety. A trial of dronabinol still makes sense at this time because it would allow for the use of an FDA-approved and thus likely safer treatment under the close supervision of his primary care doctor. What? Are you nuts? I mean, that's terrible advice. I mean, why just leave the guy alone? Actually, he had come up with a pretty good solution that worked well. Taking straight THC for this kind of problem just doesn't make any sense. The guy who was the expert didn't know what he was talking about. And it reminded me of a quote from a biography of Stalin, which tells you something about me that I read biographies of Stalin, from the author who said, most of these authors, talking about his competitors, blend a lack of the most elementary knowledge with a willingness to make bold assertions. So we have dealt with some of the limitations. Now, you know, evidence-based medicine certainly has its roles, but we have to recognize its limitations as well. And it's best suited to looking at pharmaceuticals and not looking at botanicals. And we have to keep in mind that when different people do different EBM meta-analyses, they often come up with different conclusions. Is there some kind of middle ground? I mean, can we use the critical analysis of EBM and also listen to what our patients are telling us? Because they know something, and we should at least give them the credit of listening to them. So here is an example that would never, ever make it into evidence-based medicine. This is actually the only study that I'm aware of migraine. It just came out a few months ago from University of Colorado. It, in this study, they had their clinic patients that they looked at 121 charts. So they didn't actually look at the patients, they just looked at the charts, who had been diagnosed with migraine and then came back. The migraine headache frequency decreased from 10.4 to 4.6 headaches per month, P less than 0.0001, with the use of medical marijuana. Most patients used more than one form of marijuana and used it daily for prevention of migraine headache. Okay, what's wrong with this study? I mean, it gave positive results. Well, actually, lots of stuff is wrong with it. They actually had 262 patients, and 141 of them didn't come back for a second appointment. Now, why do people not come back for a second appointment? Didn't work, or it worked and I don't need you anymore, or, you know, you're a turkey, I don't want to see you again. There was no standardized definition of migraine in the study. I don't know that these doctors, there were all kinds of doctors, that some of them were resident doctors. I don't know if they know how to make a diagnosis of migraine. There was only one person that looked at the data, and that's the guy who was first author. So he's highly biased to get a positive result. There was no standardization of the preparations, and some people use edibles which don't work for migraine, rather than the vaporized, inhaled, or sublingual. And despite biases in the favor of response, only 40% got a positive result. But if you back it off and look at 262, which is the right way to do it, the intent to treat, it was only about 20% response rate. On the other hand, they're right. It works. There's no question that inhaled cannabinoids, vaporized, smoked, sublingual, will stop migraine headaches and will reduce the frequency of headaches. The paper is absolutely on target. So we're left with this dilemma of, looking at evidence-based medicine and not finding evidence, and at the same time, if we listen to our patients and have to do it critically, they're going to be telling us some things that just simply aren't in the analyses. And I mentioned the problem with the list. So here in New York State, this is the list that the politicians gave the doctors and said, these are the situations you can use medical cannabis in. ALS, cancer, epilepsy, HIV, Huntington's, inflammatory bowel disease, Parkinson's, multiple sclerosis, neuropathies, spinal cord damage. So obviously their consultant was a neurologist. And what's important on this list is what's important to the doctors, not what's important to the patients. What do the patients say? Well, survey studies have their own problems, but they're kind of interesting here. There's the first paper here, 100 patients from Hawaii, and they can say multiple things. You know, I use cannabis because pain, and I have trouble sleeping, and I've got ADHD. I got that wrong there, ADHD, yes. Pain was by far the most common, almost universal, and then some other things. In Michigan, you could only have one reason, your top reason, and pain was 87%. In Los Angeles, you can do all kinds of complaining. You can complain about anything you want to, and it was all over the map. And insomnia and anxiety and stress, I guess, says something about Los Angeles, were even higher than pain. This is what my patients have told me over the last few years. And there's the examples here, every one of these has been, somebody has said something about 3 times. Now there's some wacky things on there. And the third column down at the bottom is, I actually had patients who use cannabis for hair regrowth. Doesn't work. Why would somebody use, it makes your hair fall out. Why would somebody use it for hair regrowth? And I asked him, he said, why are you using it? You know, he was convinced it works. And he said, well, I had some cream, and I thought I should put it. Okay. So from these studies and from our experience, one of the things we learn is that single reasons are uncommon with cannabis. Most people have multiple reasons for using medical cannabis. And the reasons that they tell the doctor are often highly influenced by the law, because in California certainly, if they tell me they have uncontrolled pain, that's easy, you know, I can sign off because that is within the context of the law, that's okay. If they tell me that they're using it to regrow hair, then that is not within the law, and I really shouldn't give them permission to go buy cannabis at the dispensary to make their hair regrow. So there's a strong influence there for the patients to come up with the same list that the politicians have come up with. There are some reasons that patients tell you that are never in the EBM trials, and they usually don't tell anybody unless you have a good relationship with them. One of the very common reasons, especially in working class, you know, manual labor kind of patients like field workers and construction workers, is they're afraid of becoming addicted to opiates. And they used cannabis as a way to avoid opiates or to get off of opiates. They're afraid of prescription psychotropics because it deadens them, it makes it hard for them to think and to work. And they use cannabis as a way of avoiding those. Some of them say, oh, I want to use something natural. You know, and I, as a fairly conservative, straight doctor, I kind of grimace when they say that, but okay, I know, whatever. I don't like going to doctors. Well, you know, that doesn't make me feel very good, but, you know, I guess I understand. Or they can't afford the drugs. You know, the drugs are just getting ridiculously expensive. Just, you know, ordinary kind of drugs are going up at a rate of 100% every few years. And a lot of these patients just can't afford to fill their prescriptions, and weed is, they can grow it themselves, grow their own medicine. And then sometimes they're just trying to avoid the truth, and that's something you really have to be sensitive to as a doc. I mean, there may be something seriously wrong there, and they're just trying to avoid facing up to it. And several times I just have to say, look, you have to go to a doctor, you've got something serious, you're nuts trying to treat it with cannabis. You know, this is, you need MRIs, you need this, you need that. And then there's the hidden agenda, the martini syndrome. The way that case report or the case study from JAMA, the way that guy was using cannabis is the way that mostly blue-collar workers, it's how they use it. They work all day. They don't use it during the day because they don't want to lose their job. They don't use it during the day, but when they get home, they hurt, they're anxious, they've been doing this kind of heavy labor for 20 years, and it's beaten up their back, they've had some injuries, they get home, they take a few hits to relax and to relieve the pain. Then they can be normal in the evening, hang out with the family, do whatever they do, and then at bedtime, they take some more to help them to get to sleep because the pain is keeping them awake. And in a way that I'll just briefly mention that, you know, they're not actually using cannabis for sleep. What they're using cannabis for is pain relief, and it allows them to sleep because the pain is better. So I have tried to, in this book I was blathering about yesterday, I've tried to come up with some kind of compromise and try to not only have just the facts there, the basic science, the animal studies, the human studies that I tortured you with yesterday, but beyond that, what do the patients actually say? And putting those two together, how can we come up with some reasonable recommendations? And I'd want to take two examples that just weren't very well covered in any of these studies. Now, insomnia brings up an important issue that evidence-based medicine never considers. What are the alternatives? Over-the-counter drugs for insomnia don't work. As I mentioned, a lot of people with insomnia don't have insomnia. They have pain, they're stressed, they have PTSD. That's not insomnia. They have trouble sleeping because they have another problem. Remember yesterday, pleiotropy. Wonderful things about cannabis is a single medication has multiple actions, so that something like what we call insomnia, that in fact, may have nothing to do with the sleep disorder, may be helped by cannabis because it works in so many different areas. Well, suppose their doctor says, oh, I don't use that marijuana. Here's a prescription for Ambien. Oh my God, it's terrible stuff. Highly, highly dependent on it. People get stuck on it for decades and they can't get off because of the painful rebound insomnia. The benzodiazepines don't work very well, and you have the same problem of feeling like you've been beaten up the next morning when you have to go to work. And then low-dose antidepressants, and basically you're using the low-dose antidepressant for its side effect, because antidepressants like amitriptyline make you drowsy. It has nothing to do with the primary action of the drug, it has to do with the side effect of the drug. So EBM doesn't necessarily take into account the fact that the reason you're using cannabis is nothing else works. I covered that pretty well. Okay, IBD also didn't get into the studies. Now there's good science behind IBD. There's good reason to think about cannabis as an important treatment of inflammatory bowel disease. There are actually some good randomized clinical trials. The problem with it is that they're small. It's hard to blind because they're given placebo cigarettes versus weed. And the patients can tell the difference. I mean, you can't blind it that way. And so these studies always get kicked out from a meta-analysis or evidence-based medicine. But they're consistent. Here's one of my patients, 20-year-old man, developed moderate of ulcerative colitis when he was 19 years old as a college freshman. He lost a semester of work, and then while he was going to the doctor to try to get his bloody diarrhea stabilized, and it wasn't controlled, I mean, it wasn't cured, but it was controlled. He started losing weight because it hurt, and this is a common symptom, that whenever he ate, he got pain. So he didn't want to eat. And also because he was sick, he lost appetite, and then he got depressed because he couldn't go to social events. He was afraid he would have bloody diarrhea at the baseball game, you know, and that's not a nice thing to have happened with your friends. And then his friends, not his doctor, his friends said, you know, hey bud, you know, do you ever think about taking a couple hits? It'll probably help you. So he got some cannabis from his friends and tried it, and by smoking half a joint in the morning and in the evening, the symptoms went away. He controlled it. So he went back to his gastroenterologist, and he didn't tell him. And the gastroenterologist, as we do as doctors, said, oh, it's wonderful. The treatment I'm giving you is finally working. And he said, yes, doctor, yes, doctor. So the doctor started reducing the doses of his medication, which, you know, that's a good thing because it wasn't working anyway. And then the patient came to me for his cannabis card so he could get it legally at the dispensary. And I went bananas. I said, what, you lied to your doctor? You know, you can't do that. So the doctor is making decisions on the basis of incorrect information and incomplete information because you lied to him. So he went back to his doctor and he said, you know, I'm sorry, I didn't tell you the truth. I'm using cannabis and that's why I'm better. And the gastroenterologist said, oh, whatever. Okay, to finish up, some words of wisdom from Great Britain. This was an interview in the New York Times last December. Sir Richard Peto was interviewed on his paper, Does Happiness Itself Directly Affect Mortality? Now, this guy got a big grant to study whether being happy means that you'll live longer. Anybody have an opinion on that? It doesn't. Sorry. But believing things that aren't true isn't a good idea. I love it. This is my California conflict. There's a guy walking past a medical wine store on the way to the dispensary. And then I lost the final bit of, the slide fell off. The final bit of words of wisdom came from a Dr. Jonathan D. McCue, who is my son, who is a plastic surgeon in Minneapolis, and he said, you know, Dad, I hope you're correct because you're awfully convincing, which always gives me pause because, you know, if I've talked you into something that's wrong, I do apologize. I'm sorry about the Sativex study. I'll have to go back and look at that. I just assumed they were Sativex. So